Morning, folks. We'd like to record this session in the absence of anybody wishing not to consent. We'll go ahead and record and transcribe. Speaking of the recordings, we are still learning our way through the technology we have in the department, and Lorian wasn't able to access the recordings directly, so I ended up having to download them all off of my account into someplace into the server. And then we'll be moving it. Lorian will be getting access and being able to move it to the YouTube channel that we have as a department. So Lorian, I haven't forgot that. I'm sorry. It's just been a very busy week trying to get through everything for today. If anybody does not want to consent to recording, would you please come off mic and say so? Okay. All right. So we'll go ahead and get started. I apologize that I have not sent out an updated agenda for today's meeting. There's a lot of moving targets that we are dealing with at the moment. And actually today's meeting will need to end probably about 5 minutes early, 10 minutes early. Some of us have to go to a different meeting physically. I will be remoting into that meeting. But I need to be there on time. And I've been dealing with some technical challenges these days from Teams. I don't know if anybody else has had some troubles with Teams lately. Maggie is smiling.
I hate Teams. I just hate Teams. That's all. I'll Zoom you any day. Just let me Zoom you.
Same.
Yeah.
Same
we get a
here
lot
too.
we get a lot of functionality out of it, but it is a little challenging at times. I don't even know if they fixed it, but earlier this week, one of the icons that we use to access channels was missing, and it was a Teams thing, a Microsoft thing. It wasn't a departmental thing. Okay, so that being said, when we last met, we talked a little bit about the supportive housing, ARPA crisis state plan amendment, and started talking about the new community reentry program. And I wanted to give an update on intakes for people in IMD settings, and I don't think we got through all of that agenda. So I am mentioning that to refresh memories from the last meeting. And hang on a second, I want to make sure everybody is getting admitted. Yep, somebody's letting them all in. Okay, great, thank you. So on supportive housing, we have another update, and I think that it is a pretty short lift for us to just talk about. I think I had shared with you folks that we had a problem with one of the codes that we were going to use, the code for the per diem supportive housing itself for both transitioning and for sustaining. And we worked with CMS on that front. And then we had to work with our coding specialists in the Division of Medicaid Services to come up with a code. And we came up with code H2021. And Jeff, I believe that is called Community Wraparound Services, something like that.
That's right.
Okay. It's a code that some of the other states are using for their supportive housing benefit, and it is a 15-minute unit. We are looking at the rate of being $16.93 per 15 minutes, and that is based on two factors. One is the allowable budget for that service backed into the number of units that we think on average a person may need. So Jeff, I know you did a lot of the research into what other states were using, and I don't know if you want to provide any additional insight as to how many hours that we base that utilization and that budget at.
Sure. So both of those services, the sustaining and the transition services, are limited to 150 hours annually. We know that it'd be very rare that someone maxes out the 150 hours transitioning and 150 hours sustaining in the same year. So we didn't want to put that at 300, that would have brought the rate down significantly. But people could reasonably max out over 200. So I think we settled on somewhere around 220, 225. And that brought us into the range of the rate is sort of on par with what other states have that rate set at. So that's something that we will likely adjust as we see utilization, but we'll see how it goes to start with. I was at a conference recently with a lot of other states were there talking about their implementation of their supportive housing programs, not all 1915I, but 1115, and heard some of the things that they've dealt with. We have some, and I learned some things for sure, and I also gained some insight into some benefits that we have in the state that other people are struggling with. So I learned a lot there. I think as we move forward, we'll continue to tweak a little bit. Another update on that is we do have a number of providers enrolled now, so we're moving forward on that front. And yeah, we'll keep moving forward on it. I think we do need to wait on that code because they needed to do a get the state plan amendment approved, and then the code will be enacted. Is that right, Diana?
Right. I was going to add that part. So because we had to switch codes and rates, we needed to do a state plan amendment. And because this is a 1915I rather than just sort of our regular state plan price adjustments, we can't do we can't get approval to turn the code on. I mean, we can't turn the code on until we get approval. Most times we will do a state plan amendment effective a certain day, and we have a number of days to be able to submit that state plan amendment. So for example, for the mobile crisis ARPA, that state plan amendment was submitted late June, but it is retroactively effective to April 1st once CMS approves it. For this type of estate plan amendment, we can't do that. We have to get the approval first, and then that rate can be turned on. Kelly, your eyes, I'm trying to read your face. Does something sound off on that? Because I know that you're a Medicaid guru. Nope. Okay, good. All right. So we apologize, but that's part of the delay that we're dealing with at the moment. We are in contact with CMS, though. I don't expect there to be a significant delay. I am guessing that it could just be that the subject matter experts for this particular state plan amendment is perhaps on vacation, because I did not get a reply from him either, which is kind of strange. So we are very close, and thank you for those of you who did get your enrollment packages in ready. I think it was Jeff, it's Manchester. Who else got theirs in?
CLM and Nashua we're showing up as provider in the provider type search.
Okay. We are still meeting weekly on just the actual workflow of how this process will flow through, because under the design of this 1915I, the first sort of door of entry or the first activity has to be in the housing continuum space at the regional access points. Jeff, do you feel comfortable just doing a high level flow through of what we envision will happen once a person makes contact with the regional access point?
Sure. So that's at the regional access point is where they would do the eligibility screening for any of the housing programs. If someone seems to be to meet the eligibility for the supportive housing benefit at the regional access point, they would, as they always do, gather all the documentation they need for the programs that they're referring people to. They would submit that to Bureau of Housing Services, where we would check, where they would check and make sure that their benefits are open, that their Medicaid is moving. At that point, they would contact me or Lorian, and we would do a service review to see which agencies are already working with this client, to see if they're already receiving targeted case management somewhere. All of this would be reported back to the regional access point. who would coordinate those next steps, like who's going to be providing the targeted case management and coordinate who's going to be providing the actual supportive housing services at that point. There is the conflict of interest issue with the 1915I. So with some exceptions, the agency providing the targeted case management can't be the same agency providing the sustaining and transitioning services. There are some exceptions to that, but that's how it's that's what we're going to have to focus on.
So can we pause there for a second?
Sure.
So that conflict of interest, that is for the targeted case management under that benefit package where you folks already have targeted case management, that the state plan reflects that you can still provide those other services. That's not that targeted case management is sort of in that special circumstance case where you folks can still be the provider of the supportive housing service, the sustaining or the transitioning one, because the case management is going to be billed under the CMH system. It's not going to be billed under the 1915I. So it's not targeted case management as a supportive housing service at that point, right? That's why we can do that. But and it would be the same way for area agencies. It won't be that way if you're a CFI case management agency, and it won't be that way if you're getting targeted case management under this benefit package. And it's hard when we're working on this because we've got to work on it thinking about all the different pathways. It can get very confusing. So I wanted to provide that clarity.
Yeah, the workflow document that we've been putting together, it's with all the contingencies, it's massive. It's pretty big.
Right. So I'll pause there because I suspect people have some more questions about this.
Hey, Diana, Cheryl Putnam. A little confused in the sense that I originally thought that the issue was that if somebody's already opened and receiving targeted case management from a community mental health center, they would in fact be the provider that would be providing the housing assistance as well, because that's part of targeted case management. And I thought originally it was that they wouldn't be getting both. So now you're saying they can get both targeted case? No? Okay. Hoping you can clarify.
Yeah, no. What we're saying is that if they have targeted case management, like under the CMH system, that targeted case management service is provided under the CMH system. And then the CMH system can still provide that supportive service for transitioning or for ongoing sustaining. So what your original understanding is correct. You can provide the case management and you can provide the supportive housing service. We're not going to recommend in guidance this, but we just want to acknowledge that, clients have those choices that they can make. And in the event there was a client that didn't want targeted case management, it wasn't getting it from the CMHC, but the CMHC wanted to do the supportive housing service and they were good with that, that person could get targeted case management out of this benefit from the housing system. And then the CMHC could still do the supportive services if that's what folks wanted to do. I don't envision that's going to happen. I suspect that if you're working, I keep thinking about the instances that you shared with us, Patricia. If you're working with someone and they have not wanted to onboard fully with community mental health services, this might be a way for them to make that decision. So I suspect that would more be the case. And your regular ongoing clients that you're already providing targeted case management for.
And I suspect the RAPs would encourage that for continuity of services and for speeding the process along. I don't know that anyone in the midst of experiencing homelessness is going to want to delay the process by finding another set of services. And so I think that would be pretty rare.
Kelly?
Thank you, Diana. I just want to make sure that I'm clear in my head. Initially, there were 150 hours for supported housing, transitioning and sustaining. Are those the right words, Jeffrey?
Yes, yeah.
Okay. And I know that it sounded to me like you're saying, well, we weren't going to go to 300, so we're settling on a different number. Is
That was-
that,
I'm
okay, go
sorry,
ahead.
finish your question.
No, no.
That was just for the rate setting process to sort of estimate the number
Okay.
of hours that people would be utilizing. So the limits and caps on the services haven't changed. And there is we've retained authority to permit waivers for those hours. So if someone is capped out at 150 on transition and they're still looking for a place, we can approve additional hours in that case. So the hour change I was talking about, that was just in the context of rate setting. So we could put a rate that made sense for the
Right,
service.
if we had divided the budget that was associated with those 300 hours, it would have made a lower rate. And so we looked at other states' utilization and we were able to bring the rate up by doing that.
Thank you. I
Patricia?
was just trying to figure out if I had
Oh.
to go back and do calculations or workflow changes or anything, but I appreciate it.
Patricia?
Yeah, so I'm just gonna ask the question again, just to make sure I'm clear. For the folks that our homeless outreach team, for instance, as an example, might be working with who are not active patients of the mental health center, if you will. They haven't done an intake, they haven't agreed to that. When we go through the regional access point and that happens, and because we can't provide both TCM and any kind of housing support, say at that point, is it the regional access point that assigns who will do what? Meaning, you mental health center will do this part of the service, and then someone else will do the other part of the service. Do I have that right?
Yeah. And I feel like the word assign it, I want to think about it, they'll collaborate with the referring provider. So like if Manchester was referring the individual for the service to the regional access point, once we do that screening process and we say, okay, they're not getting any of these services anywhere, they'll look to find somebody to do the targeted case management. And if it was Manchester who made the referral, then I would think the regional access point would say to the individual, would you like Manchester to provide this service for you? And Manchester would provide that supportive service. Did I get that right, Jeff?
Yeah, that sounds right.
Okay. And then, so there's going to be a need for us, it sounds like, to have some agreement or agreements with these other providers so that we can have communication and collaboration, coordination. So at some point, will we know who these other providers are so we can proactively do that?
That makes sense. And yet so the targeted case manager in that case would be doing the plan of care, and the supportive housing services, the other agency would be working from that plane of care. So there would be collaboration there. Does that make sense?
Yeah, so it says that original slide deck that we were using, they'll make the referral to the other needed services and supports based on the person-centered plan, monitor and update the report, make contact with the providers of those services, collaborate like that. So that is part of what we envision. That's part of what was in the 1959.
Right. So, we'll need some agreement with those partners.
Yeah,
Mm-hmm.
that makes sense. Yeah, and I know this sounds inconvenient. I think that the reason it's stated like that, the conflict of interest, is so people aren't referring people to themselves for services. That's that's the
I get
reason
it.
for the conflict. But it does make things a little tricky.
And Patricia, in terms of some agreement, do we need to put something like into the guidance on this to speak to that? Because I was thinking of it more along the lines when you're working with people that are part of someone's care team that aren't already on the CMHC, they're an external partner, and how do you collaborate with those partners on care?
Yeah, I mean, from a care coordination standpoint, we either need releases, but we also, if it's like a system setup thing, meaning it's a systemic, this is going to be not just one person, me and, Dr. So-and-so. We have to have an MOU or some agreement with each other about what each party will do, right? So I think those are the kinds of things, and to your question, yes, I absolutely think it should be in the guidance, because we're going to want to understand and do those things with, we may have some MOUs with people already, right? But we don't know who the partners are, but it probably doesn't say homeless, housing support services in there,
Right.
So we may have to just alter that or something, but yeah. So, I mean, we have, because of CCBHC, we have some of these agreements already, but for coordination of care. But, others may not. And there might be new partners. I don't know.
Well, I'm glad you mentioned it though, because, we'll be doing this sort of more through secure email in the very beginning, but we do want to build out the workflow through the closed loop referral, and that carries consent and privacy and things like that within that framework as well. So Jeff, if you just note that, and it can go on our discovery work with the Unite Us team as well.
Yeah, thank you for talking that through. That's
That was
we'll
really
take a
helpful.
closer look
Thank
at that.
you. Kelly?
Can you remind me, because I know Melissa addressed this in the last meeting, how many people do you project to be served by this benefit, at least in year one?
It's in the budget is developed on an anticipation of 60 people in year one, which obviously I'm seeing faces like, oh, that's not enough at all. And we recognize that, but I think it goes in as a conservative projection initially, because we know that, we've got to get the providers onboarded, et cetera. And like, for instance, if most of the people already have targeted case management, that share of the budget isn't going to get spent down very much. And it could provide for even more people to get covered. The other direction, if everyone needs 300 hours, the budget's not going to go as far as we wanted it to go.
I think some of the reason for the conservative projection is that there are providers from the housing system who a few have signed on as potential providers who've never billed Medicaid before, and there's going to be a learning curve. So I think that's why we were projecting it to kick off a little slowly, but we do understand that this could, especially for the sustaining services, that's not necessary for someone to have received the transition services to receive the sustaining services, that we could end up with pretty large capacity.
Just to follow up, what happens if you got 500 referrals?
Well, that's where we go back to Medicaid and our finance gurus and say, what do you want to do? I mean, we know what happens in the DD system. We have a wait list, right?
And we do have
Mary,
so coordinated entry
sorry.
does have the wait list capacity. So that's what would happen initially.
Dr. Burnett?
Hi, thanks. I just, I want to just highlight a few things. So evidence-based supported housing assumes that individuals with behavioral health conditions will be supported in getting the behavioral health care. I know everybody knows that, but I just want to highlight it. And so if a person was not yet in behavioral health care, the targeted case management would support and link and continue to support people in getting the behavioral health care. And community mental health centers are ideally positioned to provide that. And in particular, you know, for people with SMI, they would be, this is really designed for people with SMI, and they are the organizations. So I'm hoping that these confusing pathways and processes is not going to inhibit that. So for example, if it ends up being a path team that links and connects with an individual, if there are barriers to, if they've already created a relationship with that person, it just isn't person-centered to require them to go elsewhere. Or, you know, I just want to again say, I want these pathways to be person-centered. Think about the individual who's dealing with all these complex organizations and systems and papers and forms, and you know, if we want to remove barriers, not make barriers towards people getting housed and getting services. So I'm just putting a plug in again for that. These are very vulnerable people. This is very hard. They're at the most vulnerable times in their lives, and we want to facilitate, not inhibit. So just one more, repeating my plug for that. And this whole problem with the conflict of interest to self-referral. I know it's a federal legal requirement, but an individual makes relationships, and making them not be able to continue that relationship is just not person-centered. So I'm just saying it again, in my advocacy role.
I love it. That was great. Thank you. Because that's, we recently regrouped in sort of that workflow design. And originally we were thinking we want to expedite access. So we were originally thinking once the application, if you will, came through to the Bureau of Homeless Services, that we'd work very quickly in an expedited way to have the policy team, you know, look into MMIS, see if the person was open for what services, et cetera. Start the prior authorization process at, you know, with those providers. And then we said, wait a minute, that we need to connect the individual with the providers first. If they're getting targeted case management somewhere, let that targeted case manager know, just in case the referral didn't come from that targeted case manager, just in case the person accessed the housing continuum all on their own, wanted to go back to that person, back to that clinical team and say, this person that you're working with is eligible for this service and is open for this service. Do you want to provide that service, or how do you want to handle it? Like, so we said, forget it. It's going to go back to the regional access point. They work with the CMHCs all the time. They can have that conversation. You folks can come up with your plan to meet with that individual to see, you know, how to get them involved in services. And then knowing what once you've done that, then you can say, you know, to the policy team, we need a prior authorization for this. And so that's exactly where we went back to, Mary, is it's got to be about the person and trying to connect them to care.
And I think in our world, that's going to happen. I think from when the care manager is someone else, I think if it's a CMHC or a PATH workers or whoever it might be, we would want that to always be a part of the care plan. I guess from my perspective, like, you know, in terms of what we're trying to accomplish.
Right. Of course. Right. There is another piece is that we want to recognize self-determination, and that services that are recommended aren't compulsory for the housing piece. So that's something we recognize, but services that, you know, the workers working with the folks, services that will be recommended for sure and encouraged, and people won't be abandoned for not participating, right? So
sort of similar
that's
to
also
Bridge.
part of the piece. Yeah.
Kelly?
Last question. Are you still anticipating that in the situation where they're wrapped, and the person is getting targeted case management from us, or maybe not even, let's assume they're not, that in order for us to provide that service, we would have to go to a different wrap to make sure they can be referred back to us?
We've talked about this. We're still working that out.
Thank you.
Yeah.
There's it's definitely in the plan in a very distinct way that this starts with a regional access point. And then the conflict of interest is very much in there. So just for that, for the centers that are both a RAP and a community mental health center, it is a unique situation to work through.
Yeah, especially the BHS team has been talking about that a lot and figuring out how to manage those that issue. So we're those conversations are ongoing. Yeah.
So a couple of other things, the code for the supportive housing transition and sustaining, it's the same code. We're going to use modifiers to differentiate between those. Jeff, have we talked about if we wanted to use any additional modifiers so that we could still track the individuals by subpopulations? So you know how we use U1, U2. Have you folks explored that?
We haven't really. You know, we've only talked about the modifiers in the context of differentiating the services. Which piece of the supportive housing service we're talking about, so we can track the hours. We haven't talked about subpopulation monitoring.
Okay. Do the centers think it would be helpful if we had the modifiers attached to your subpopulations also? I mean, from your own EMR perspectives, et cetera. Patrick, you lifted your head.
I assume that you're talking about just for the people that we're serving, because obviously you have the whole eligibility process that you'd have to complete to have the person. So a lot of the people would just be passing in a non-eligible modifier, and then you'd have to get the other entities that aren't community mental health centers to understand they'd have to pass the non-eligible modifier. Is that what you're talking about? I mean,
I'm talking about the ones that the individuals that would be your clients that they already have a U1 or a U2 attached to them for the services that you're.
I wouldn't want to speak for all the centers, but my sense would be that would be relatively straightforward and simple for anybody that's currently receiving service. We would definitely be able, I believe, to attach a modifier. If somebody else has a different opinion, you know, please. It would only happen though if the person was already evaluated for the eligibility status. So if someone came in and place was serving as a regional access point and they did not yet complete that termination, it could, getting back to Mary's point, potentially slow the process down of getting those people a service.
Right, and it doesn't need to exactly. So there's a pro and a con there. Yeah.
Yep.
Okay. Any other thoughts on that? Okay. All right. So hopefully we won't be meeting next week. I haven't sent the cancellation out, but I'll be on vacation. So we'll be missing a meeting, or we might rededicate it to another conversation if we can get one teed up for that. On the ARPA crisis state plan amendment, we did submit it, and I thought we were going to get pretty quick approval, and somewhere in the past week they had some additional questions. So I have a meeting with the CMS team and DMS next week. Hopefully we'll get some good news there soon. Again, I think the largest positive thing about it for the community mental health centers is that you won't have to deal with presumptive eligibility for CMH services to handle the full episode of care. It won't tie in all of the HEM 400 requirements in terms of, having to keep them on board as a client and going to that uncompensated care space at some point. It's just in the regular Medicaid state plan. CMS did have a particular question because for crisis stabilization services, just whether they're in a stabilization center, whether they're out of your office, that we had set up to 30 days per crisis episode. And they had a question about, is that a firm max, or are we going to allow for potentially longer than that? So that's a brand new question that we have to tee back up an internal conversation on. On the pieces that we had put in for the Crisis Stabilization Center. Even though we mirrored language significantly, like over 90% from another state's state plan, they have asked a few additional questions on that front. So there's a list of the staffing requirements, the minimum staffing requirements, I should say, and like we say, a clinical director, and they want us to add in what are the qualifications. They want to know for each of these types of professionals, what services are they going to provide? So they want us to build it out more deeply than a previously approved one, which was approved in a recent year. So we need to tease through some of those things with them for what their expectations are. And then we may need to regroup with some, particularly Lakes and CLM because of your plans on the Crisis Stabilization Center. You know, you already have the contracts for that, to make sure that we don't too rigidly lock in the framework of the staffing component. That was one of the reasons why we picked the previously approved state plan amendment, so we could look at that and maintain a little bit of flexity for the center build. Steve?
Can we have input into what those positions are, what the job descriptions would be?
Can you have what?
Input into what those positions, what the job descriptions for those positions will be.
Yes, that's
Is
what I
what-
was saying. I'll get from CMS what their expectations are for which levels of details, but then I think we need to regroup with particularly CLM and Lakes Region on that front at least, so we can make sure we don't border, ourselves in too tightly. We want to make sure we have some flexibility.
Yeah, thank you. So do we.
I figured as much. Yes. All right, so that's moving along. I had started to introduce the community reentry program that we've applied for under our SUD SMI IMD demonstration. I wanted to know if we were still planning to move forward with that, because I'm not asking you this. I'm just backing you into my thought here for a second. But I was in a meeting with the Medicaid team and with CMS yesterday afternoon, and there was a lot of discussion about budget neutrality and the president's budget, and some of the language in the demonstration gets a little wonky in terms of the lesser logic, et cetera. And I came out of the meeting fearing that the community reentry program might not be able to move forward for budgetary restrictions. But I communicated after the meeting with our waiver person, Carolyn Richards. Some of you know Carolyn from previous work. So she's in that waiver position working with our consultants at A&M every day. And I said, are we still planning on being able to afford to do this? And she said, yep, we are. The department is between the two departments. We still are pretty confident that we'll move forward with that. And CMS has been approving more and more states on that front. So hopefully we won't have any problems with that. We chose a 45-day benefit rather than like California has a 90-day benefit. So we chose a 45-day one instead. So we're hoping that we won't have a problem with approval on that front. Now, did we get into the details at all about what that package was the last time we met? Do folks remember? I know we missed a week for the holiday. Okay, so the vision for that reentry benefit, and I should have had the PowerPoint ready to look at it again with you folks, but essentially what's going to happen is within the Department of Corrections, a resident of the state prison system who is anticipated to be released within 45 days They will be working with their DOC case manager. And if that case manager, in preparing the individual for returning to the community, that person has a history of substance use disorder or of mental illness, they will be talking to that individual about this benefit package. They will already know if the person's Medicaid is in suspense, because we actually don't shut off Medicaid. Everybody thinks we do. We just really suspend them. But if they look like they're still going to be able to have Medicaid opened up, if they look like they have a history of SUD or mental illness, they'll have a conversation with them about this program. They will make a referral. They'll initiate a referral for the person to get these services. The managed care organization that the person is going to be opened under will be will provide managed care organization provided care coordination, which means they're not handing it off to a different provider. They have to take lead on coordinating and wrapping around that person's needs. And that means if they have the history of mental illness, the MCO's going to try to connect them to the CMHC. If the person refuses and says, I had a provider in the community before, I'd like to return to that provider, then the MCO will be connecting that person to the other provider. But for the CMHCs, they would be reaching out to the CMHCs to get the person connected to care, to do like an intake. Telehealth, we anticipate this is all going to be telehealth, because we've worked through DOC and addressed the fact that it would add too many days to the timeline and administrative process to deal with the security issues of someone going behind the walls for this work. So it would be through telehealth. So they will be able to get an intake. They'll be able to start getting targeted case management, and they would be hopefully be connected to a peer support as well. So those are the services, the intake, targeted case management, and a peer support, all before leaving the prison system, before being released into the community. And when upon their release, they would be releasing with, I believe it's 30 days of prescription medications if they're already on prescription medications. Steve? Oh, you're muted.
So just to clarify, is just the state prison, or is the county jails involved in this as well?
It's just the state prison at first. CMS has asked us if we have interest in going beyond that, and we expressed, yes, we do have interest. But for now, as we start, because we have to still deal with the budget neutrality issues. So we're starting just with the prison systems. And I can't remember the total, but I think it was approximately 600 individuals a year that are releasing, and it's a lower number than that would have that history of SUD or mental illness. Dr. Burnett?
So sorry to ask a hard question potentially, and you don't have to answer it today, but just for consideration, is there going to be a mechanism through which high utilizers can be prioritized? Because if we can really wrap our arms around high utilizers, there's a great potential for savings across the system in helping people be able to remain safely in the community with treatment that might prevent a lot of emergency room utilization and then reincarceration. So you don't have to answer it, but my hope is that we could find a mechanism through which to especially target and help high utilizers.
So thank you for the question. Because it's a 45-day benefit, and we currently know accessing the community mental health centers, right? I think most centers have a wait list right now. Is that correct? No, not all of them. No, some. Okay, not most. Some do, right? So we know that there is.
It's more complicated than that, Diana. Because people are triaged based on acuity and level of need and services, and some of us have open access intakes, so there's no yes or no on that.
Okay, thank you. But the design for the managed care organization, in particular, the department's expectations is they will be prioritized to get an intake with whomever the provider is going to be.
And
We
said
Go
provision
ahead.
will be especially important, substance use treatment. With the high utilizers, commonly, I think over half have a opioid use disorder, and access to that treatment will be especially important. So for those here who are CCBHCs providing said treatment, you know, that this is a really high need population where we can really make a big difference for them.
Absolutely, absolutely. And as part of both the CCBHC models implementation and the demonstration for the community reentry, we are moving forward to add targeted case management for the SUD population. So that will be very helpful as well. It would be it won't be the monthly like what you get for the CMH population. It would be a per diem based targeted case management, similar to what we have in the long-term system for CFI. Maggie, I'll take you, and then Brittany is involved in a lot of these work groups as well. So she's probably going to add more content to what we're sharing here. Go ahead, Maggie.
So you said intake, peer support, and targeted case management as telehealth billable in that 45-day period. Did you mean to include CPE? Because I hope to God you did. Because if we're going to have CPE, comprehensive psych eval by one of our psychiatrists or nurse practitioners, because if we have to see that patient fairly quickly and be willing to pick up the meds in 30 days, we should have that service as soon as we can have that service, right?
Okay, thank you. That's great. Jeff, can you just make a note for that? And Brittany, you might have the answer on that.
So I don't necessarily have the answer on that, but before what I was going to say, I do want to say, Jeff, it might be then to make a note for people that are going to be using this benefit and are CMHC eligible, as in that SPMI population, right? Making it part with the DOC that meds are 30-day release instead of 14, with the option of an additional 30 days where it's built in and they're expecting it for these individuals, instead of having to make the case manager and people request it additionally, because that can often not be able to be done in the time period before. So just making sure we're specifying that to meet what Maggie's saying as well. And then also just for people to be aware for how the New Hampshire prison system works is to identify the individuals and then to identify the level of care for individuals that are going to have substance misuse, right, related concerns. They do get evaluated by a LADAC, which will give that level of care, which will help determine the level of referral that goes to the community. And then within the prison, they use the same SPMI indicators that the centers use, as in they're using the same diagnoses. They're using the ANSA as well. So they should have a pretty accurate way to match people up to the correct level of service, because they're using the community-based services. And then they use the IROS, not the IROS, they use the Ohio risk assessment to determine within the first 48 hours when someone is entering into incarceration, and that identifies mental health and substance for their long-term planning. But they are using most of the same evaluation tools that you guys are using. So they hopefully will be able to then match people appropriately to the level, just so you're not thinking you're getting 600 referrals right off the bat.
Right. And that's why I'm
Just
saying
so
it's
you're
a
aware.
subset of the 600. It's not going to be 600. And so I don't know if you were on when I was sharing this, Brittany, but the 30 days is what they'll be able to leave with. But we made a note about the potential for the other 30 days. Patricia, I'll get right to you. There's one thing I want to share. Well, there's two things I want to share. Because they're going to be opened in managed care right away, the first service you guys provide to them, it's going to start counting on your PMPM because it's managed care. This is not starting in fee for service. So that's a huge thing. The other huge thing, it means any of your directed payments that are associated with like the timely prescriber after an intake directed payment, that would qualify for the individual if you make sure that you get that timely prescriber within those days as well. So there's some certain strategies there that we're looking at that will be helpful on that front. And then there's a piece on eligibility. We are going to work towards them being, I don't know if we're going to do it through guidance, to take existing language in HEM 400 where when a person is discharging from a facility, that you're able to presume them to be eligible for services right away. We're going to do something like that for these so that even if they come out and they, because they've been incarcerated for so long, they don't have the record of functional impairment that is needed for you to make your determination of CMH eligibility because they've been stabilized for so long. For example, it's going to be able to allow you to deem them eligible from the beginning, basically. Patricia?
Okay, so now I have another question, but I'll start with the first one, which was the MCO coordination. You called it wraparound, but I'm assuming this is not any in-person care coordination. It's all phone referral, much like they do now.
I think that I don't think it's going to be in person. It's going to have to be by telehealth. Yes.
Okay. So, or phone or whatever. It's okay. In the PMPM thing you just mentioned, so the reentry reimbursement then really wouldn't start until the intake is completed. Any services prior to intake would not be PMPM. Like if you happen to, I guess I'm trying, it really wouldn't happen until that intake was completed because then at that point, they're active in your system.
Right. In theory, yes. I mean, I don't think how could you essentially say that it's medically necessary for someone to get a peer support service if you haven't assessed the individual and developed a care plan and said this is what the person needs?
Yeah, I understand that, but right now we have an intensive transition team that goes into our county jail. I'm just going to use that as an example, to help engage people who may not be completely accepting, if you will, of services that they might need. And they're going in and talking about the mental health center and what we offer and so forth and trying to really engage them. We do that because it's part of a model that was under the IDN when we did it, and we felt, and it worked really well, and it got people engaged, and they had a person when they came out. They didn't, it wasn't like, and that was we did 45 days. So they would come out and help them transition through the intake to their clinician so that we had a person who was, this is something I always say, was Velcro and not Teflon. Meaning like they didn't slip away from us and they didn't fall off by the wayside. We were able to kind of get them to stick. And so part of, that's what I think about when I think about reentry, because really it's a tough space. And there's a lot going on, and it's often MI and SUD, and there's all these things. And so I just bring that up because it'll probably be something that we may still continue and work with the managed care companies around it. We do it at our county jail.
And we do anticipate the DOC case manager and the community-based case manager to work close together as well. But thank you for sharing that. Kelly, did you still
Yeah.
have?
Oh, can I just ask one more thing? And it has to do with the managed care company referrals. I would hope if that is involved, that they are aware enough to be referring, say, for us, someone who really needs opiate replacement to our MAR clinic if the person is coming to the mental health center and not to some separate entity where the care will no longer be integrated. So I guess, we can work with the care coordinator, but I kind of want to put that on the radar because the whole hope is that we're really doing all we can to have this be an integrated care approach to these individuals. So, we really.
Brittany, when we are in the next work group on that, maybe we can talk about this a little bit, and it could be that we want to have like a special session with some representation for the CMHCs there to talk about this with DOC, like bring everybody together to talk about this.
And I think it'd be helpful too, not even just for this project, but in general, because right now the case managers there do the referrals and there's different services within different centers. So particularly things like what you were just talking about, Patricia, it might be good and they might need both the managed care and the DOC, just a quick snapshot of, right, on top of mental health, refer for these services. And we can kind of just each center, and then they have their little name in their list, just so people, even without this particular service, are making the most appropriate referrals, because the case managers really do go off of, in the prison, their own internal resource guide, which it just depends on if people happen to stumble upon an updated resource, and then if they happen to share it with all the other case managers, because they're not all in the same location. And then if it goes to all three facilities. So that just might be something to discuss too with DOC, how the best way to do that.
Thank you. This is targeted for January 1st of 25. And our plan is to flow it also through the closed loop referral solution as well, so that you could get like discharge content, perhaps some of the clinical records and stuff that DOC might have to be able to flow through that, and the MCOs as well. They will be using that. Lisa?
Hi, thanks for the opportunity. I think I want to back up a little bit of what Patricia was saying. Over the past couple of years, the Governor's Commission on Mental Health and Corrections has been working on trying to develop, get some feedback, get some direction. The information and data on high utilizers is now available with great detail. And yesterday, their final report from JRI, Justice Resource Institute, was presented to the committee. And we have some suggestions in there about how to make sure that this reentry and the 1115 waiver component of it is successful. So I'd want to reinforce what Patricia said about it might not just be a psychiatric admission or an intake. The care coordination component and the peer support component needs to be accessible early on in order for there to be a success in the reintegration as well. So that report I will share. It just came in this morning, and it's the final report. And I think if there was to be a meeting, you may want to make sure that people who were sitting in that for the past couple of years, that you have them at the table too, and we can talk about where some of that alignment is from the corrections.
Great, thank you. Can you forward a link to that report to me, please?
Sure. Yeah.
That'd be super helpful. So we will try to get a session set up so we can talk more about this, the integrated piece in particular. While you were saying that, so administrative rule, we were talking about the functional impairment and the history that you need to see, et cetera, and doing the intake. Give some thought to if, in particular for the care coordination piece that you folks were just talking about, if we should also look at in the guidance, like waiving any other particular piece of 426 to the degree that you would be able to get those other services in very early rather than sort of the normal process of you have the intake, then you have the prescriber, and you know what I mean? If there are other tweaks that you think that we would need to address in guidance to help this along, that would be super helpful. Thank you guys all so much. We have to jump now. I appreciate all of you. Have a great day. Have a good weekend.
Thank you.
Thanks. Bye.